In transplant-eligible patients, we have moved to quadruplet-based regimens. One anti-CD8, one proteasome inhibitor, one IMID, immunomodulator drug, and dexamethasone. And it has become standard of care. And then you transplant the patient. In non-transplant-eligible patients, transplant-ineligible patients, we have learned to move from 2 drugs to 3 drugs because we've been able to develop with our partners, the pharma companies, the novel immunotherapies, particularly anti-CD38-based immunotherapy, that were very safe, so we could go from 2 to 3 drugs and improve everything, depth of response, survival, not affecting, not impairing the quality of life of the patients. And so the question is, can we imagine that we would move from 3 to 4 drugs, even in transplant-ineligible patients? There's going to be a number of studies next year that are going to read out and tell us more about, is it manageable, is it feasible, is it safe enough, and how much you bring to the patients in terms of activity and efficacy. And then it's going to become extremely exciting because then you're going to have access to either 4 drugs, 3 drugs, 2 drugs, and then you're going to really start to have options to tailor the treatment. We keep talking about tailoring treatment, but the way we tailor treatment today is that we give the same drug to all patients, and as it goes, we adapt according to safety. But what if, instead of adapting according to safety, you would, from scratch, from the get-go, have the right bet on the right regimen for the good of the patients, knowing that in transplant-eligible patients, you have a lot of different patterns: fit, intermediate frail, unfit, and frail patients. And so the question is, would that be possible, so from scratch, to add diagnosis, to propose to some of them a quadruplet, other a triplet, and maybe other patients a doublet? Does the frailty definition necessarily means that the fit would have the quadruplet and the frail the doublet? So I think starting next year with the approval, hopefully the approval, the registration of the quadruplet-based regimen, we're going to have a whole range of possibilities. And so the notion of tailoring treatment from scratch and not according to safety profile and depth of response at some point is really going to become something real and something we're going to have to be smart with and learn how we do things. Because in transplant-eligible patients, the notion that everything is MRD driven is not necessarily so obvious.